Today's topic, again, I'm John Waterbor from the UAB School of Public Health, Department of Epidemiology. Right downstairs, my office is in room 227C, and I'm going to talk to you today about cancer statistics, cancer epidemiology, and control. This first presentation is from the American Cancer Society. As you can see, the American Cancer Society Mid-South Division is headquartered right near UAB, a few blocks off 5 Points South. American Cancer Society is a private foundation as opposed to the National Cancer Institute. Don't mix those two up. The National Cancer Institute that funds CARES, that's the National Cancer Institute, part of the NIH, National Institutes of Health, branch of the federal government. ACS is a private company, you might say, and it does fund research. It also is do-gooders, and they're do-gooders in a good way. They help cancer patients who are disenfranchised, have financial needs, transportation needs, etc. And that's, of course, a national organization. And part of the work I do at UAB is with the ACS and also with the Alabama Department of Public Health in Montgomery. Anyway, this slideshow, Cancer Statistics 2016. First of all, since we're talking 2016, it's not over yet. A lot of the numbers you're going to see are projections. And again, these slides will be on the website. I'm not sure if they're on the website yet, but if you look later, they will be there. Every year, the ACS on their website, cancer.org, that's an easy one, that's a good one that they captured, posts this sort of slideshow for people like me who are teaching cancer epidemiology, cancer statistics, cancer control. So let's go through it. I have only 1 hour and I tend to talk too much, but I'll try to hit the major points. Man and woman estimated new cancer cases. In epidemiology, we call that incidence with an NCE. The incidence or occurrence of new cases. So the process of cancer incidence or cancer is really cancer diagnosis. It's an event. You are hereby diagnosed with cancer. You are then an incident case. You remain a prevalent case until you die or get cured. In cancer, we usually don't say you get cured because that's going out on a limb. So that's Epi 101 with incidence and prevalence. Prevalence is a state of being. You're a cancer survivor after your diagnosis. You're a survivor until you pass away. Okay? So what's new on this slide, we don't have a lot of time for questions and answers. What's new to me as compared to the 2015, 2014, 2013 slideshows of these past years are these two numbers. This is the first time I remember when the projected number of new cancer cases among females is higher than males, because we've been teaching, and some of the other slides that are not caught up quite to this projection, some of the slides are actual data from the past. This is the first projection I've seen where the total number of cases of cancer of all types combined together, diagnosed in the US, are projected to be higher, not much higher, but higher in women than in men. The reason for that, we don't again have time to quiz back and forth because I got to cover a lot of stuff. The main reason is that the prostate cancer incidence rate, which is only among men have prostates, the lung cancer incidence rate among men, that's male and female, those rates among men, incidence rates, are falling faster than the lung cancer incidence rate in women, and the breast cancer incidence rate in women is maybe not falling, maybe not rising. Anyway, it's a complicated statistical thing, but anyway, that's something new. So what is the most commonly diagnosed cancer in the United States in 2016, which isn't over yet, but it's a good projection because there's a lot of past data. Prostate cancer, number one. So about 1 out of every 5 men diagnosed with some sort of cancer, 21%, 1/5, have prostate cancer. On the female side, if you can remember these exact numbers, terrific. I would say about 1/3. If you're cornered on the elevator with President Obama or Vice President Biden and they start quizzing you, you have 30 seconds to give them a really cogent and thoughtful answer. What percentage of cancer cases among men are prostate cancer? About 1 out of 5, 20%. Among women, about 1 out of 3, not quite that, but that's close enough for government work, as we like to say. Okay. What's number 2 in incidence? Lung and lung. What's number 3? That is male, female. Colon and rectum, colon and rectum. If you add those first 3 numbers together, that's 43%. If I did my math right, that's 50%. So the point there is if you were in public health, which I am, many of you are not, but some of you are, and you have a program to try to eliminate or diminish the number of new cases, control cancer. Where the money is in terms of high numbers, there may be other considerations, are 3 to 4 sites. That is, if we could eliminate or cause a decline in incidence of prostate cancer, breast cancer, lung cancer, colon and rectum cancer, that's about half the battle. Now, that's easier said than done. But the point of this slide is, again, what's common and what's not. So if you get into cancer epidemiology, cancer control, and if you're doing even lab research and you want an appreciation for, gee, what cancer am I working on? I'm working on a soft tissue sarcoma project. Is that a leading cause of death? No. It doesn't say you shouldn't work on it. It doesn't say that it's not important. But these are, again, in public health terms, what we look at. Trends in cancer incidence rates. Now, what's a rate? In epidemiology, a rate is number of new cases per 100,000 people or whatever set number over a given time period. So the convenient way to express a rate, because the numerator comes out to double or triple digits, is per 100,000. So it's, what we're saying is per 100,000 people without a certain cancer on January 1, by December 31, how many per 100,000 have been diagnosed with cancer? So this is cancer incidence rates, as you can see. These are data, pretty good, up to 2012. In this particular graph, some people would say, some epidemiologists would say, well, this is interesting, but it doesn't tell me much because all cancers are considered in one bucket. That is, in this case, in this example, the female cancers, a case of lung cancer, breast cancer, ovarian cancer all count as one case each. So what's happening to make the overall female cancer incidence rate rise gradually, but it's rising? What's happening with the male rate? Well, to know that, you have to go to the next slide, because that gives you the detail on which cancers are occurring or being diagnosed at a higher or lower rate as time goes on. One thing, again, before we get to the next slide, this, the both sexes is, again, you don't add rates, it's a weighted average. So the both sexes rate is a weighted average of the red line and the blue line. This is disturbing to an epidemiologist who'd never seen the data. That is, when you have such a large, rather sudden increase there. Does anyone know real quickly what happened there? Was there nuclear fallout? Did a lot of people start smoking? Or why did the male cancer rate go steeply up, and then why did it go back down? Does anyone know? PSA test is it. A topic for another day. Again, I'm teaching cancer epidemiology and control this summer, and I'll teach it next summer if anyone wants to take it. Here to answer that question or kind of corroborate things. Trends in cancer incidence rates. This is males. These are data because it's, again, back to 2012. Before we get to prostate, you can see that in kind of your lifetimes and a little before, maybe, from 1975 to almost the present, these other cancer sites, well, lung and bronchus, gradual decline, colon and rectum, gradual decline, urinary bladder, little increase, and so forth. The graph or the site that sticks out to most people's attention is prostate cancer. This is a situation where there's a screening test called the prostate-specific antigen, PSA test. Unfortunately, it's not prostate cancer-specific antigen, and it became the vogue back in the late 80s, early 90s to get a PSA test for men to screen for prostate cancer. Now, again, it's a long, I give a separate lecture in this in my course, don't have time for it now, but the idea is that there's the adage, the harder you look for something, the more you're likely to find it. Now, screening or early detection is usually good, and we'll talk about that in my second little slideshow. In this particular site, though, what happened was lots and lots and lots of men were diagnosed under the microscope by our pathology department and other pathology departments as having prostate cancer. However, further research after this big, again, increase showed that a lot of those cases are actually indolent, that they're not doing anything, maybe better yet, not discovered. What we'd like to know, though, remember prostate cancer is the leading cancer, and it is on the list of causes of death, causes of cancer death. What we'd like to have are some biomarkers so that at the time a man is diagnosed with prostate cancer, we could say, well, man number one, you have that kind of prostate cancer. It's probably never going to do much of anything. There's an adage, many more men die with prostate cancer than from prostate cancer. Other men diagnosed with prostate cancer, you might say, you wouldn't say this to a patient, but you got the kind, it's going to kill you soon, unless we operate or do some other treatment. That all being said, lots of men were diagnosed with prostate cancer. Here we have the phenomenon of kind of sweeping the prevalent pool. That is, after a few years, everybody and his uncle and his grandfather got screened, and there weren't that many people, many men left who wanted to be screened who weren't screened already. So that, at least in part, explains that. And going backward, that's such a big player, numbers-wise, it pretty much caused the bump in the overall cancer incidence rise. Women, breast cancer incidence is certainly number one. A rather odd shaped curve. It's not very regular. Do notice, because we'll call your attention later, we'll talk briefly about childhood cancers. Notice the rate per 100,000, we're talking in the double digits, like 50, 100, double and triple digits. So breast cancer, again, incidence rate back in 1975, call that 105 or 110. It's been creeping up there, okay? And breast cancer is certainly a major public health problem, a major health concern among women and men. 1% of breast cancers occur among men. The men, I'm saying, are more concerned about the women than themselves, kind of a rare disease for men. Again, for the other so-called major cancers, we'd like them all to go down in incidence rate over time. They're not all doing that, but at least they're not taking off. So again, you would say, if you had to pick one, if you're a public health person and like, where's the money in terms of what do we want to focus our budget and our attention on, many people would agree, for women, breast cancer. And there's lots of breast cancer research out there, UAB and otherwise. One thing we look at here and at other universities is so-called cancer disparities. And this is kind of a complicated, again, not my slides. I wouldn't make it the slide quite this way, but here it is. What this says is this. If you first look at, just look at the red bars, the male rate. So which racial ethnic group has the highest cancer incidence rates? Well, it looks like non-Hispanic black. So in epidemiology, we talk about Hispanic or non-Hispanic as being ethnicity. Race is white or Caucasian, African American, so forth. So you can be you can be Hispanic and white or Hispanic and black. So that's how that's broken out. So among the red bars, non-Hispanic black is the highest incidence rate. That's among males. Among females, which are in the blue or purple, whatever you call that, what's the highest? Well, it looks like non-Hispanic white, and there's the numbers there. And we could calculate some relative risks. So actually, even though it is true that the so-called cancer burden in the US is inordinately high among minority groups, African Americans, Hispanic populations, and American Indians, so-called Native Americans, it actually is the case that white women, for these data, again, for this period of time, have a higher incidence rate than these other groups. So there's the red bars, the purple bars now kind of both together. It is, again, true compared to the projections on slide number one, which are now, maybe things are changing. Male is always higher than female. So the incidence rates within any group, within any pair of bars, the red is higher than the blue. And that's how it's been. But again, things may be changing in real recent years. It's nothing to sneeze at because it's important. Okay, now if you break down incidence rates, not just by male and female, but you put in race, then you see white females, black females, pretty close together. And black females actually have a somewhat lower incidence rate. Cancers overall, not for every particular site, putting it all in one data set. Not much of a difference, but whites are a little higher. There is a big gap, though, racial disparity in cancer incidence rates among black people, black men, sorry. So white males, black males, they pretty consistently follow one another. But that's something, again, a lot of research goes into why is that the case? Is it something to do with, in black males, increased exposure to the causes of cancer? That would make sense. Is it some difference in diagnosis? There's lots of reasons it could be. Okay, lifetime probability of developing cancer, we call in epidemiology, we call that risk. Risk is a futuristic term. It says, what are the, you could ask an epidemiologist or physician who knows public health, what are my chances of getting, you name breast cancer, lung cancer, prostate cancer, in the next year, in the next 5 years, in lifetime, okay? So calculations can be done essentially by life tables. That is, we have a data set of people like you, of your age, race, sex. We have data, and maybe we want to find out more about you in terms of I don't know, occupation or other maybe family history. We could then give you a projection, or you might say educated guess, because you're like someone who we have data on, or like a group of people we have data on. So the risk, it has been said for a couple of generations, the risk of males getting cancer of some type is 1 in 2. This is in the United States, okay? So if you're a male sitting here and you haven't had cancer yet, if the projections are correct, 50% of you will get cancer of some sort, okay? What's the most likely? Well, again, it reflects which cancers are more common. Again, things can change over time, but the things we think first of about are prostate cancer, lung and bronchus, and so on, okay? For women, no easy ride either. 1 in 3 instead of 1 in 2, so that's a little better, but that's still 33% chance. And of course, the leading type of cancer you would be concerned about getting is breast cancer. Now again, these are data based on large groups of people. If we did on you an individual risk assessment, that is, we looked at you, or now we can look at your some genetic markers, we can look at family history, that is, we could add to your data file before we give you this answer, 1 in 3 or 1 in 7. That would modify the answer. But these are, again, for men overall, women overall, okay? 5-year cancer survival rates. Cancer survival is important. Again, what we usually say in epidemiology is once you are diagnosed with cancer, most people do not die immediately, some do, but you are then called a cancer survivor. And we don't usually use the word cure because a lot of cancers can recur years and years later. So you're usually viewed as a cancer survivor. One thing that is still calculated in order to compare with previous data is so-called 5-year cancer survival rates. In epidemiology, it's not a rate, even though that's what the slide says. It's a proportion. A rate should be over person time. A proportion is a static thing. So how you would calculate a 5-year survival rate, I'll just call it 5-year survival. Let's say everybody in this section is diagnosed with cancer today. All we want to know is 5 years from today, what percentage of you are still alive. That's just a proportion, simply 10 over 20, 15 over 20, whatever it might be. How has this changed over time? Well, again, for all sites, it's an interesting statistic to look at, but again, I would say, well, explain this to me, because what's going on with the individual sites? Back in the mid-70s, about half people survived 5 years. The reason 5 years is used, partly just for historical reasons, is because a couple generations ago, it was thought if you survived cancer 5 years, you were cured. So hospitals and cancer programs would advertise or publicize their high 5-year cancer survival rates, like we do a good job treating cancer here, because 80% or 60%, whatever the number was, survived 5 years. Now we know that 5 years is not a magic. It's good news. If you didn't recur or die from your cancer in 5 years, that's terrific. But it's no longer thought to be a marker for a cure. However, to compare with previous data, we still calculate this. So all sites together, you can see the improvement in the last column here of the most recent year. Look at the improvement for breast cancer survival up to 91%. Now again, we don't have time to get into stage distribution, but if you detect breast cancer early, when it's near the normal, so-called stage 1, survival is about 95% or maybe even 98%. If you detect it or diagnose it late, statistics are much worse. Okay? Colorectum and so forth. Okay, so you can see that, well, let's look at prostate because that's good news. That's now 99 back to prostate cancer. The 5-year survival, 99%. And that gets back to the idea that the PSA test does a lot of diagnosing of prostate cancer. Many of those cases are kind of histologic diagnoses and, again, are over time observed to not be fatal. So there's a big denominator, and a big chunk of the number is this variety of prostate cancer that some physicians have said, if you live long enough and you're male, you're going to get prostate cancer. But a lot more men die with prostate cancer than from prostate cancer. Okay, the thing here that is very disturbing is cancer of the pancreas. Is anyone working on pancreatic cancer in their project? We used to have a good couple of researchers here at UAB who have gone to other universities. What's the 5-year survival for pancreatic cancer back in the mid-70s? 3%. Pretty poor. Yes, that has more than doubled, almost tripled, and now it's 8%. But that means pancreatic cancer has a high case fatality. Case fatality means the probability you're going to die from the given disease. So the case fatality for the common cold is essentially 0. Case fatality for pancreatic cancer is very high, almost 100%. You don't live long enough to die from something else. That's how rapidly pancreatic cancer can get you. The news, again, for most other cancers is much better. Okay. By race, again, the black or African American population, for a number of reasons, and I can give you generically what some of the reasons are, but it might be a different explanation site by site. The survival is not as good. So there's just the arithmetic difference. So overall, this is in the US, white people survive longer than do African Americans from whatever kind of cancer they get. Now you can see the gap here. Again, prostate, for the reasons I mentioned, I won't say it again, these are like almost off the scale, whether you're white or black. But for these other sites, again, there's a fair difference in survival. So what are some of the generic reasons? And again, site by site, there might be a different explanation. Well, if white people are in general diagnosed earlier by screening or by frequent contact with the medical care system, if they're diagnosed early, that is, the cancer is not advanced, and treated promptly, that would go along with better survival. Okay? Related but not quite the same, for socioeconomic reasons, if there is a higher percentage of white people compared to black people that can afford the best treatment and they go to the UAB Comprehensive Cancer Center or to the Mayo Clinic and they get the latest treatment, whereas others maybe get the customary treatment, whatever it's been, that could be a reason. So again, it varies, I think, site by site. Okay, okay, let's start over, almost. Deaths. These are men and women. Again, remember that the numbers for incident cases on the first slide were in the 800,000s. Okay, so these are numbers of not incident cases. This slide is on deaths, or called mortality. So one thing that we want to know about cancer is how many new cases per 100,000 people per year. Another thing is how many deaths from that cancer, usually again as a mathematical convenience, per 100,000 people per year. So the death numbers are more in the 300,000 range. That's a lot. In the so-called steady state, that is, things are tooling along, you know, those graphs are going a little up or a little down over time, you would not have the same number of deaths as new cases in a given time period, unless maybe you're talking about pancreatic cancer, where in a given time period you might have 10 new cases and 8 or 9 deaths. May not be the same people who are diagnosed in that period, but again, a steady state means a steady relationship between, over time, number of new cases, number of deaths. Okay? So the answer to how many new cases of cancer occur in the US from that first slide. Just remember about 800,000 men, 800,000 women. How many cancer deaths? About 300,000 among men, 300,000 among women. Okay. Now, the order, again, if you have a photographic memory, I don't, you can memorize all of this. It would help you on the national boards or something. The first two sites are kind of interchanged. Remember, in incidence, number 1 and number 1 was prostate and breast. And the reason I remember that, and maybe some of you already have a feel for this, prostate and breast are both hormonally caused and hormonally treated, sometimes cancers. So there's a lot of parallels if you get into cancer epidemiology. Breast cancer, prostate cancer, there's a lot of commonalities, and one is like a hormonal relationship. So breast and prostate tend to parallel each other in numbers for whatever set of reasons. Prostate and breast, though, fall to number 2 in mortality because what rises to number 1 is lung cancer. Lung cancer is not as bad as pancreatic cancer, but quite a high case fatality. That is, if you get lung cancer, a very good chance you're not going to live long enough to die from something else. You're going to die from lung cancer, even more so for pancreatic cancer. So again, if you wanted to remember the essentials, you can see for the national boards, lung and bronchus, number 1, this is cancer deaths as opposed to incidence. Number 2 and number 2, male and female, is prostate and breast. They kind of go together. Number 3 and number 3, colon and rectum. And number 4 and number 4, so it's easy to remember because it's really the same other than breast and prostate. If you add these numbers, 35, 4, that's 50%. If you add those numbers, that's, I think, 55%. So right there you know of all the people who die from cancer in the United States in a given recent year, about half die from those 4 sites, or those 4 sites. Okay. What's been happening to cancer death rates? Declining. Now that's interesting and that's great, but we're going to have a little bit of a public relations issue soon, because do you know what's declining faster than the cancer death rates? The cardiovascular disease death rate. Right now, heart disease or heart diseases is the leading cause of death in the US. Cancer is number 2. This year, we don't have data, obviously, on this year yet, and maybe we only have good data on last year, but in the next couple of years, even though the cancer mortality rates are falling, we observe that the mortality rates from heart diseases are falling more quickly. So cancer, we are making progress in controlling cancer. That's the good news. The bad news for public relations, you might say, to explain to the New York Times and explain to CNN and so forth, is cancer will soon become the leading cause of death in the United States. Because even though the cancer mortality rate is falling, the heart disease mortality rate is falling more quickly. So there's going to be a crossover. Okay? You heard it here. Trends in cancer death rates. Men. So again, what stands out, if you're someone in cancer epidemiology, cancer control, cancer death rates among men, bingo. I mean, all these, look at all these graphs here. This is not every kind of cancer, but representative. So forget the red line for the moment. That's around a 45, a 48, whatever, call it 50. All of these numbers of rates, cancer death rates, are like 50 per 100,000 or less. Look at the lung cancer mortality rate. It skyrocketed all the way to over 100. Now, why did it go up that high and why did it go down? Smoking. About 80 to 90% of lung cancer cases are caused by tobacco use, at least in this country. There may be other countries where there's no tobacco, so that wouldn't be true. But here, that's the case. Why did it start going down? As far as we can infer. Smoking cessation, the message that it's a bad thing, unhealthy, okay? This is some detail on those other couple of sites. Females. Lung and bronchus never, well, I won't say never got off the ground. That's too extreme a statement. It never, as compared to the last slide, see this big rise even back, 1930s about the first year in the US we have pretty good cancer data. Even from 1930, like a continuous bingo. Females, again, did not take up, it's kind of a cultural thing, did not take up the smoking habit in big numbers until about World War II in this country, the 40s, late 40s. When they did, yes, they started to get lung cancer, But by the time their graph was kind of taking off, the smoking cessation message came into play. So you don't see for women that the graph went all the way up there. Luckily, it didn't go too much higher than that. Okay. Cancer death rates, and again, this is similar with the blue and the red, but now we're talking about deaths, not incidents. You can see that males over females, males over females, males over females for all of these different groups. And again, these are data, so and pretty accurate. To go on that note, again, our most accurate data in cancer are mortality or death data, because there's death certificates that are documented, signed off. Occasionally there's an error. That's a documented thing. The incidence numbers we have are obtained from cancer registries. The cancer registry is a system whereby cancer is made essentially a reportable disease by law. So in Alabama, we have something called the Alabama Statewide Cancer Registry. So every new cancer case gets reported to Montgomery, and that's the way the incidence data are gathered. Every hospital, every physician, every clinic that diagnoses a cancer case, it goes there. Okay. Trends in cancer death rates by sex and race, and you can see things are not getting a lot worse, but they're not getting a lot better. I mean, I won't comment further. Again, what stands out is black males way the heck up there. I don't like the slide, so I'm going to skip it. Report me if you want. Okay. Trends in cancer incidence and death rates in children. Just a few slides on that. If you go into cancer epidemiology, and I'm sure all of you will, is there anyone who will not go into cancer epidemiology after this lecture? Good, okay. If you become a cancer epidemiologist, one thing you decide early on is, are you going to study adult cancers, which is what we talked about up to now, or childhood or pediatric cancers? Whole different ball game, different bunch of sites, different causes, way different numbers. So remember, I called your attention to the rate per 100,000. Remember, I said it's double and triple digits, 50, 100, whatever, for adults. This is children and adolescents that are defined there by age. These numbers are 2, 4, 6, 8, 10. So childhood cancer, sometimes called pediatric cancer, much lower incidence rate, because the highest here we're getting is, again, about 20. Much lower mortality rate. Again, the incidence rate is going to be, unless there's some event there, the incidence rate is always going to be higher than the mortality rate, maybe a ratio of 2 or 3 times. Okay. Cancer incidence rates among children, defined as 0 to 14, and in adolescents 15 to 19. Again, to call to your attention, and some of you, I'm not sure if anyone here, is anyone working in Children's of Alabama? I don't know if they're on the job yet. Okay. So what cancers are you working with?
I'm working with marrow transplant. So
oh, okay. How about you?
Same thing, actually.
Okay. If you get into pediatric cancer again, the causes we think of for adult cancers, like smoking, drinking, no physical activity, obesity, da-da-da-da, well, infants are not around long enough, we hope, to be smoking, drinking, and doing other bad things. So their cancer sites are a different list. There they are. And the causes are different. And the numbers, again, are much lower. Okay. There's, again, brain and I think that's CNS, central nervous system, leukemia, soft tissue. Okay. The other thing that's good about pediatric cancer is, again, there's a lot of more genetics involved because, inborn genetic errors, is the idea of survival. Survival of childhood cancer is in general better than adult cancer. So that's all we'll say about it now. Trends, again, has improved. So when you have, again, it's not as good as 100%. If you have data that suggests leukemia, 5-year relative survival is 85%, well, we'd like 100%, but 85% is pretty good, okay, compared to at least some adult sites. Okay, this was a slide that the ACS threw in at the last minute and probably is out of order, but I left the slideshow the way it was. We now have enough data, again, for statistical purposes, to look at some other minority groups other than African American and Hispanic, where the numbers are kind of slim in this country, but maybe increasing. So you need to put some numbers together for several years in a row. And that's for your interest.